Yeah, welcome you all for this evening and good evening to one and all, which is over here as well as which is as a audience listening to the this unique seminar or webinar you can say, which is drug-induced lung diseases. We are giving drugs for the treatment of the diseases, but if drug causes diseases, then what? So we are going to discuss regarding this thing tonight with all our esteemed panelists. Actually, regarding this drug-induced lung diseases, first and foremost, one person was there that is called as Dr. William Osler, who raised this issue of drug-induced lung diseases, and he recommended or suggested or he demonstrated the pathophysiology of opioids and pulmonary edema. That is, we can call it as a drug-induced pulmonary edema. That was in 1882. After that, in 1972, Rojanu, who demonstrated around 20 drugs, those are related to the drug-induced lung diseases or drug-induced lung toxicity. So after that, in 2010, there were around more than 433 drugs which were introduced or which were elaborated in the demonstration of this drug-induced lung toxicity. And hereafter, gradually, yearly, this as new molecules were coming in the in our practices, so they have recommended in 2015 there were more than 600 drugs which are liable or which were or demonstrated their toxicity as far as lung is concerned. Why our lung is getting too much toxicity from all of the drugs? So actually our lung or respiratory system is unique. It has circulation or blood supply from the both pulmonary as well as bronchial circulation. So that may be the one of the reason, and it has a lot of the this cytochrome P450 enzymes also, that also will be the responsible for the development of this drug-induced lung toxicity. So with this fine this introduction, I would like to introduce our today's panelist. My actually as a moderator, myself, Dr. SK Toke, pulmonologist working in the Pune area as and the Pimpri Chinchwad area. Then our next panelist is Dr. Subhankar Choudhury, which is from Rourkela, who is working as a who is attached as a pharmacologist in one of the medical college over there. Then our second panelist is Dr. Abhishek Prajapati, who is a pulmonologist and who is working in the Karamsad. Then our third panelist is Dr. Mohammed Hussain, who is from Hyderabad and who is working and who is well known as a pulmonologist in the Hyderabad area. Then our fourth panelist is Dr. PC Kathuria. Actually, his name is itself is coming as National Institute of Allergy and Immunology. So he has done a lot of work in the allergy and immunology, who belongs to from Delhi, who is a senior most, I believe in today's our panel. Then our fifth panelist is again from the Delhi, Dr. Pawan Gupta, who is actually not in India as of now. He has gone somewhere outside India for the lung transplant, some fellowship, and thanks to him for joining from there itself. He is doing fellowship over there for the lung transplant. Thank you, sir, and welcome for our today's unique webinar on drug-induced lung diseases. And our last but not least panelist for today's presentation is Dr. Smitakshi Medhi, who is working as a pulmonologist in the Guwahati. So I welcome all of you from my bottom of the heart, and I would like to thank first Dr. N.H. Krishna sir and Dr. Atri Gangopadhyay, who is backbone of our CCI, which is unique governing body as far as patient is concerned in all over India. So So with this short introduction, I would like to hand over the stage to Dr. Abhishek Prajapati for the presentation for 15 to 20 minutes on the drug-induced lung diseases. So welcome Dr. Abhishek for this today's talk on the drug-induced lung diseases.
So, good evening, everyone. First of all, thanks to CCI for giving me an opportunity to present this talk today, and thanks to Dr. Toke sir for kind introduction of myself. So, I will present very briefly for next 15 to 20 minutes overview of this topic of drug-induced lung disease. It is a very vast topic. We cannot cover in 15 20 minutes. I will try my best. So if we check the history of this topic, now it was first William Osler in 1880 around. Uh, he uh, he mentioned in the literature the opioid-induced pulmonary edema, and that was the starting of the science of drug-induced lung diseases. Then the world tried to understand that drug can also cause some lung injury, and we should screen of this terminology too. In 1972, then Dr. Rosno and their colleagues did so much of work in this drug-induced lung injuries. Around 20 drugs they mentioned, which might lead to the lung injury. And they also emphasize the importance of blood, oxygen, radiation, mineral oil, and lymphangiogram, which can cause the lung injury. So blood products may cause transfusion-associated lung injury, which is called now TRALI. Oxygen leading to lung injury, which is also called reabsorption epilepticus, and leading to ARDS. In 2010, there is the same group of doctors, Dr. Rosno and their colleague, published a book on drug-induced lung diseases, and around 430 drugs they mentioned, which may which may cause the lung injury. In 2015, more than 600 drugs were identified, and if we talk about the latest, around 1,300 drugs are now mentioned in www.pneumotox.com in France. They have developed this online website which shows everything about drug-induced lung injury. And if you want to know something and if you have some confusion, we can check this website of pneumotox. And have developed by the French people. Now, drug-induced lung injury is a very vast topic, and it is very, very difficult to understand, and also very, very difficult to identify at many occasions. Why? Because the scope of the injuries caused by these drugs, is very, very vast. And a single drug can cause a multiple mechanism. It is not very precise that say, this methotrexate or amiodarone or specific drug causes one specific type of injury only. No. So that injuries may be from interstitial like pneumonitis, fibrosis, or as in pneumonia, granuloma, etc., to airway involvement like in warfarin, which may lead to the airway carcinosis. Now, there may be pleural effusion, there may be pulmonary vasculature involvement, there may be non-cardiogenic pulmonary edema, including KRDS, there may be alveolar hemorrhage, there may be a mediastinal involvement, there may be a respiratory muscle paralysis, there may be a neurological respiratory drive involvement, and there may be a opportunistic infection related to medication. So, the pathogenesis or the possibilities are many. If we understand the pathophysiology, the drugs and host genetics causes a very important role to have a lung injury. Exact molecular mechanism is unknown. Good models and well-studied biomedications are still we need to know, and there are likely multiple mechanisms that are completely unrelated. And single drug can cause a multiple type of injury. Bleomycin is likely to cause 29 types of lung injuries, like from pulmonary fibrosis to cavitations to granuloma formation. Like here, bleomycin may be having a mechanism of it does fibrosis with some different mechanism. Opioids causing non-cardiogenic pulmonary edema with some different mechanism. Steroids causes mediastinal lipomatosis and mechanical obstruction with some different mechanism. ACE inhibitor also causes lung injury. It causes coughing, and here also mechanism is different. Phenytoin also causes a fibrosis, and gentamicin causes respiratory muscle paralysis. The mechanism are different on each occasion. Because the lung is very unique, we all know This is only organ that receive the blood from the entire circulation, likely from if we consider that bronchial circulation as well as fungal circulation. It has different routes of access. The drug can reach to lungs via inhalation route, IV route, or oral route. It contains a heterogeneous population of cells capable of several metabolic functions like N-alkylation, dealkylation, and also contains CYP charge of 450 system like in liver. If you understand the pathophysiology, the most common pathophysiology is by drug activation or the cytotoxicity response. So here this shown molecule is endoplasmic reticulum. So this green part, if you understand, this is a drug. This drug attaches to the endoplasmic reticulum. So CYP 450s are maximum amount in this endoplasmic reticulum of the lungs. These drugs incorporated in this endoplasmic reticulum, and it converted into very highly active lipophilic material along with this cytochrome P450 system. And then it leads to lipid, protein, or nucleic acid, and then it leads to the cytotoxic injury. The mechanism is oxygen radical generation cytotoxic response. Here, cytotoxic injury or damage happen by covalently bound to protein, mostly by the bleomycin, redox recycling, like in nitrofurantoin, paraquat, or atramycin, or metabolic oxygen reaction, which happens mostly in cyclophosphamide-induced lung injury. So other mechanisms are antioxidant systems, drug activation, PI therapy, or it will lead to activation of T cells. Danger theory means it leads to the damage of the whole lung, which is also called as a diffuse alveolar damage. And eosinophilia, most common type, we would have experienced, but the none of above theory explain the reason of eosinophilia. Now, if we talk about the clinical syndrome, which may lead to the this drug-induced lung injury causes, it was in 1986, it was published in this literature, and 20 types of clinical syndromes were mentioned in that literature. And these first three mentioned syndromes were most common. They are chronic pneumonitis or fibrosis, hypersensitivity type lung disease, or acute non-cardiogenic pulmonary edema, followed by organization pneumonia, hypoventilation, bronchospasm, and so far. If you understand the chronic pneumonitis or fibrosis syndrome, these are the drugs which may cause this type of injury to the lungs, and these are the common ones: bleomycin, glusulfan, cyclophosphamide, and amiodarone, which may lead to this chronic pneumonitis. Other less common ones are methotrexate, nitrofurantoin, and statins. So oxygen and radiation are also they are also responsible for this type of mechanism or for the lung injury. And methotrexate and atopic are induced pulmonary fibrosis are less frequent. The most commonly the onset is insidious and they present with the chronic duration. Now, this is a case of 80 years old female. He was on nitrofurantoin for her chronic UTI and having a complaint of dyspnea and cough. Here in X-ray, bilateral lower tone, we can appreciate his pulmonary opacities consistent with the interstitial lung pattern on the X-ray, which is also correlates with the CT finding. Here, the white arrows shows the pulmonary fibrotic part, and this black arrow shows the bronchiectasis. So here NSIP was there on the biopsy. Another case of 60-year-old male who was on bleomycin for his non-seminous germ cell carcinoma, presented with the dry cough, shortness of breath, and diffusion abnormality. Here we can appreciate this peripheral involvement of the lungs on this CT scan of after 3 months. These intestinal opacities was progressed after the 3 months. And in this specific case, after over the 6 months, without after stopping only this bleomycin drug, these pulmonary opacities were reduced or they were going into the recovery phase. Here, the biopsy was not done. So always biopsy should not be done to diagnose this drug-induced lung injury. Here, another case of 50-year-old male on simvastatin after MI 5 years ago, presented with dry cough and shortness of breath. So recent literature emphasized the possibility of statin-induced lung injury in the Western world, like in Europe and America. They have the most commonly used statin is simvastatin, and they have mentioned such type of injury because of that. Here in CT scan, we can appreciate this bilateral homogeneous involvement of the lung parenchyma, which leading to lung fibrosis. Here in the histopathology, we can appreciate this honeycombing, and in pathology, there is in the homogeneous fibrous material deposit in the alveoli. So in biopsy, it was NSIP. So in India, we most commonly use statin is not simvastatin. So we need to know whether our atorvastatin or rosuvastatin causes the same pattern of the lung injury or not. The range of duration for the statin use was 3 months to 10 years, and it may present with the ICP type of lung injury. Now, the other clinical syndrome, if we can say it is an hypersensitive type of response, these are the drugs which may lead to this type of injury, and these are the common ones: bleomycin, methotrexate, some antibiotics, nitrofurantoin, and phenotypes, which are the most common causes of such type of injury. Amiodarone is the frequently implicated cause of injury, and minocycline may also lead to the such type of injury. Here, the most common differential will be our Loeffler syndrome, because this presentation will be acute, and this will also have a eosinophilia as well as pulmonary infiltrates, which most commonly we can appreciate also in the Loeffler syndrome. If it is an acute presentation, patient may appear with the fever. And if it is a chronic form, then patients may appear with the weight loss. So we have to keep in our mind that this if we are suspecting Loeffler syndrome, we also think about if they are this patient is on such drugs, we may also think about the drug-induced lung injury. And this is the clinical case of 75-year-old female who was on indomethacin for her arthritis, presenting with the cough, dyspnea, and fever. Here it is her X-ray, and here at her CT scan. It is showing bilateral homogeneous involvement of the ground glass opacification, and in histopathology, these eosinophils are appreciated in the lung parenchyma. Now, another clinical syndrome is non-cardiogenic pulmonary edema, or NCPE. Right. We commonly see here in cocaine, opiate, tocolytic therapy, retinoic acid therapy, and IL-2. Here, the presentation mostly will be acute, right? And the mechanism of it, which is still not well understood. It may be neurogenic, it may be oncotic or hydrostatic pressure imbalance, or it may be tight junction imbalance. In tocolytic therapy, the mechanism mostly oncotic pressure related it has been mentioned, and this neurogenic therapy theory mostly correlate with the cocaine use. So if the patient having a temporal relation, if they have used the drugs, and if present is acute, we may think about the NCPE, non-cardiogenic pulmonary edema, which usually improves with the positive pressure and diuretics. So another clinical syndrome is organizing pneumonia. It was previously mentioned as a cryptogenic organizing pneumonia. These are the drugs, chemotherapeutic as well as non-chemotherapeutic, which may lead to these such kind of injury. The most common one is penicillamine. In ancient world, the gold and penicillamine were the two most common allergic agents which will lead to such type of injury. But now gold use is very minimal, and so. But in the latest, in Pneumotox website, around 95 drugs have been mentioned, which will lead to such type of injury and organizing pneumonia. So if we appreciate the organizing pneumonia pattern on CT test, and if there is some temporal relation, some drugs have been started, and after some of duration, if it has been appreciated, we should think about this organizing pneumonia. So this is the case of 45-year-old female who was on topotecan chemotherapy for her small cell lung carcinoma. Here, the involvement is only unilateral, right-sided chest. On X-ray. We are appreciating airspace, opacification as well as industrial involvement. And on biopsy, it was a cryptogenic organizing pneumonia. So the diagnosis was drug-induced cryptogenic organizing pneumonia. So another clinical syndrome is bronchospasm. These are the drugs which can lead to this bronchospasm or type of injury. These are the most common ones we all know: aspirin and beta blockers, contrast media, and dipyridamole. The risk factors we know, it was first reported on NSAID and aspirin in 1933 and beta blocker in 1964. So the most common risk factor is underlying reactive airway disease. Aspirin and NSAID are most commonly implicated, and gold and penicillamine can also cause such aneurysm, but mostly it will be bronchiolitis obliterans. If we talk about the aspirin-induced bronchospasm, the incidence rate are 0.6 to 2.5%, and 4 to 11% in asthmatic. We all know Semter triad, eosinophilia, asthmatic patient, and nasal polyps. We all know only 70% patients have a nasal polyp. Women are more affected than men, no current convincing evidence of familial predisposition, and this failed to identify immunologic mechanism. Now, if we go to for the general approach for diagnosis and management, we should have a very high index of suspicion to diagnose these drug-induced lung injury, and we need to identify the correctly identify the drug. We need to recognize so many kind of pattern. And one important factor to diagnose is temporal eligibility. We must establish the evidence of that some drug has been started, and after some duration, some kind of these respiratory symptoms have been started. So this is an important diagnostic pattern to check. So there must be some temporal eligibility. If it's a trolley, some drug products should have been given before some 7 hours, and patient have developed pulmonary edema, then this may be a trolley because of that blood products. And in chronic case, if some drugs or chemotherapy or non-chemotherapy agent has been started, and after some few days or few months, if these symptoms have been started, then we should think about this. We should exclude other etiologies like by lab testing, chest X-ray, CT scan, PFTs, echocardiogram, bronchoscopy, and Watson biopsy. And we all know the drug-induced lung toxicity is a diagnosis of exclusion. Now, imaging, the role of imaging and histopathology in diagnosing drug-induced lung injury. If we talk about radiograph, bilateral lungs are most commonly involved, but there is no any specific pattern which is related to some specific drug. So, bleomycin can lead to 29 type of patterns of drugs. And here in this case, amiodarone causes this different kind of mechanism of the lung injury. And histopathology also varies. So, it is very difficult to understand this pathophysiology, and it is very difficult to know that which specific pattern or specific histopathology pattern occurs in specific drugs. If we talk about the pulmonary function testing, it was most commonly studied in Gossamer, bleomycin, and amiodarone. The common pattern is restriction and decreased diffusion. It is helpful, but must be aware about the limitations. Right? And bronchoscopy with bile and warts most commonly to rule out the etiologic process like infection in immunocompromises. And so one important test it is now has been mentioned in the recent literature is drug-induced lymphocyte stimulation test. It is only available now in Japan and is not US FDA approved, but it looks very promising. In which this drug is given to the patient's serum, and it is checked with some kind of some specific amount of lymphocytes are stimulated or not. If specific amount of lymphocytes are stimulated, then we may confirmly diagnose that this may be the cause of the this may be the case of drug-induced lung injury. Now I will try to discuss three main drugs which are most commonly causing the lung injury. The first one is bleomycin, the chemotherapeutic agent. It is used in solid tumors, lymphoma, and in the study of interstitial pulmonary fibrosis. It is a major dose limiting factor is pulmonary toxicity, and it causes IPF in 10% cases. It accumulates in skin and lung due to the lack of bleomycin hydroxylase enzyme, and fatal toxicity happens in 0 to 3% cases. It has a predictable decline in diffusion on long-term use of more than 3 months, mostly self-recoverable on stopping the drug. Now, if other treatments are going on, then the diffusion utilization rate further worsens, like radiation therapy. But data is still lacking about routine monitoring and no good predictors in PFT who will progress. And decline in PFT is also has a very low specificity. Means the PFT and there is a there is a decline in diffusion in PFT. Then we cannot confirmly say that this is because of our drug-induced lung toxicity only. So risk factors for this bleomycin toxicity are it is dose dependent. With a lesser dose, lesser chances of toxicity. With higher dose, higher chance of toxicity. Cumulative dose of more than 400 500 units should be avoided. If it is combined with another chemo drugs and radiation, then chances of bleomycin toxicity are high. If oxygen is given in very higher amount along with these, then also there are more chances of it. If there is renal dysfunction, if there is cigarette smoking, if there is GCSF has been used along with, and then there are high chances of bleomycin toxicity. And if it is a older age, then high chances of this bleomycin toxicity. The treatment is of the drug most common. So steroids should be used. It has been mentioned in the literature 0.75 to 1 milligram per kilogram up to 100 milligram per day. The different studies say different dose. This specific study says up to 87 patients, 5 had flare up when steroid removed, and study of 100 patients where resolution was just holding the drug. So we cannot very clearly can say that yes, stopping the drug if possible, it is mandatory, but steroid always is useful or not, we cannot say. Another drug which is most commonly used in present era is amiodarone. It is widely used in and effective in anti-arrhythmic. It is a very long half-life, and incidence mentioned in one study is 3.97% versus 1.33 in control group. The clinical features are it is a dose dependent. If it is given for more than 400 milligram per day for 6 to 12 months therapy, means if it is been given in a very larger dose and as well as for the very longer duration, then there are only chances of developing this MRD in this lung toxicity. The toxicity may be pneumonitis, fibrosis, eosinophilic pneumonia, effusion, etc. And the risk factors is more age, COPD, renal dysfunction, and PFT restriction and decrease in diffusion, and treatment is drug withdrawal, and steroids here is given for longer duration, 40 to 60 milligram per day for with 2 to 6 months of taper. It has been specifically mentioned in amiodarone in different literature. Mortality is 1 to 33% and spontaneous dissolution without steroid in some cases. Mechanism are many, but the most common mechanism is apoptosis in amiodarone-induced lung injury. It binds to lysosomal lipids and impedes phospholipases, which lead to forming macrophages, and at the end leads to apoptosis. And immunologic mechanisms also have some role. One retrospective study mentions on in which 525 patients were studied. It suggests unknown mechanism of protective effect of ACE inhibitor or angiotensin receptor blocker along with this amiodarone. Means the patients who were on amiodarone as well as ACE inhibitors, they had a lesser mortality. So here angiotensin may be playing a role, and here is ACE inhibitor was given means there may be less apoptosis and there may be less chances of mortality and drug-induced toxicity. So it is a case of this amiodarone toxicity. Here, this patient was 70 male with history of ventricular tachycardia, presented with the cough. Here, the bilateral upper lobe involvement in X-ray and in sitting attenuation seen in upper lobe. So this was the case of amiodarone toxicity. So the one last drug which I want to here describe is nitrofurantoin, because it is a very older antibiotic for UTI, but it is now being used in recent era because of its sensitivity, right? Because of the changing antibiogram in the hospitals, because of the more ESBL UTIs, and it is now sensitive to nitrofurantoin, and so many patients and so many patients are given nitrofurantoin in present era in our hospitals, and in some chronic UTI cases, it has been given for longer duration. And so that's why it is important to know what nitrofurantoin causes in lung injury. The incidence is very rare, but it is studied in very old literature. Clinical features are chronic pneumonitis, fibrosis versus acute SP-type lung injury, and other possible injuries are acute interstitial pneumonia, diffuse alveolar damage, ARDS, pleural effusion, cryptogenic pneumonia, or non-cardiovascular pulmonary edema, etc. Respective, obviously, females are most likely because in females, nitrofurantoin is most commonly given, and mechanism is oxidative stress and immunologic phenomena. In management, mild cases resolve without steroids, but lack evidence of steroid use in severe cases. And prognosis favorable with mortality less than 88% only. And one study of 398 patients having 47% of patients were symptom free within 1 day, and 88% were within 3 days. So at the end, if we conclude and summarize my talk, so drug-induced lung toxicity shows a wide range of presentation with varying mechanisms and degree of complexity and difficult to diagnose at many patients. It should always be a part of differential on a patient presenting with new or worsening pulmonary disease, and their temporal eligibility should be established in each case. It presents in clinical syndromes. Most common are chronic pneumonitis or fibrosis, hypersensitive type lung injury, and non-cardiogenic pulmonary edema. And no single diagnostic test is specific for in drug-induced lung toxicity. It's a diagnosis of exclusion. Cornerstone of therapy is drug withdrawal if possible. One-step destination to check all about drug-induced lung injury is www.pneumotox.com. So thank you all. Here I will end, and I will over to Dr. Toke sir for further proceeding. Thank you.
Yeah. Thank you, Dr. Prajapati, for excellent presentation, and you have covered almost all those things, whatever is we are going to discuss today. Uh, Thanks all. Thanks. So after this session, we are going to start with the discussion or question and answer session. Questions has been going to ask by me, and you are the people who are going to attend in. I mean, we have to give the justice to the whatever our audience to do. So first question regarding our today's webinar goes to Dr. Mohammed Hussain sir.
Yes,
So
thank you,
how do
Dr.
you
Toke.
suspect drug-induced lung disease? When
First,
we have to suspect the drug-induced lung
okay.
disease? That
I would
question
like to
goes to
thank CKI and Dr. SK Toke for giving me this opportunity. First, we should have strong index of suspicion when there is worsening of pre-existing diseases or new onset of symptoms. And it is a diagnosis of exclusion, and the relation between drug exposure and time duration of symptoms should tally.
yes,
Not like a long back he had taken, now we are suspecting, not like that. And clinical symptoms should overlap, and you should rule out common causes first, worsening of disease, infection, pulmonary edema, all those things. And whenever you are suspecting, you have to stop the drug immediately. And if there is improvement of systems, then it is a strong indicator of drug-induced lung disease.
okay, sir. Thank you, sir. Thank you.
Right.
Actually, when we are going to start any drug, as far as lung pathology is concerned, we should look for the that side effect of that drug also, and we should keep in mind each and every time. And whenever that patient visit to us, we have to ask for all these symptoms, and we can, according to that, we can decide we should continue to that drug, or we have to decrease the dose, or we have to change to other category of drug. Thank you very much, sir, for this kind answer of this question. And next question regarding um, actually family of drugs. Which family of drugs are more prone to cause lung diseases? This question I'm going to ask to Dr. Subhankar Choudhury sir, which is who is actually a clinical pharmacologist, and he is the right person to guide us on this question. Over to you, sir. Sir, you are muted, sir. You have to unmute yourself, and then only.
Am I audible now, sir?
Yes, sir. Yes, yes. Please,
Okay.
please go ahead.
Okay. If I just want to say that which groups of drug are
Yeah.
mostly responsible for assaulting our respiratory system, I would
Yes.
like to say either it is in group or either it is individual drugs. As Abhishek sir has said, three most important drugs are there. One is amiodarone, the second one is nitrofurantoin, and the cytotoxic drug bleomycin. But the incidences are too low with the amiodarone actually, because in atrial fibrillation the number of cases treated for atrial fibrillation are less, and the drug used, we can say, it's not like nitrofurantoin, an urinary antiseptic, which is widely used as compared to amiodarone. Like bleomycin, it is used in oncology department mostly, and if we go for assault in these three important individual drugs, the most dangerous assault is done by bleomycin and the urinary antiseptic nitrofurantoin. I have seen this with my sister actually. She got sick after taking second dose of nitrofurantoin, and it was there was a brief alteration in ECG for 10 to 15 minutes, after which it got normalized with supportive measures. We use it widely, abundantly.
Yeah.
Clinicians use nitrofurantoin whenever they see that it is highly sensitive. The culture sensitivity status say highly sensitive is nitrofurantoin, ofloxacin, blah blah blah. Their first choice is nitrofurantoin. But remember, sir, with I can request that there should be some black box warning by the regulatory authorities regarding this drug. Some acute cases of pulmonary edema has been reported within hours. The exact mechanism is not known. Lung fibrosis, cryptogenic pneumonia, these are after 14 to 16 days of its use. But acutely, if someone getting sick after taking nitrofurantoin, having respiratory symptom, one is acute pulmonary edema, and the second one is that is bronchospasm. It is a very chaotic drug, and vigilance is needed for it. Number one. Number two, for bleomycin, what one can say an anti-cancer drug. What we do in chemotherapy, we give maximum tolerated dose in cycles, and that's why the main culprit is the increasing dose of bleomycin, which causes the acute assault. What is the alternative? It will depend on the phases of cancer. If it is early phase of cancer, one alternative option that is emerging nowadays, that is in early phases of cancer, in whatever it is, in whatever the cancer bleomycin is used, in early stages of cancer, when number of multiplying cells are less, we can introduce metronomic chemotherapy. It has been tried everywhere, which is 1/10 of the maximum tolerated dose and given every day for longer duration, like 3 to 4 weeks, instead of giving maximum tolerated dose in 2 to 3 days and have a gap of 20 to 25 days, then introducing the next cycle. So the bleomycin induced toxicity can be prevented in early phases of cancer if we decrease the dose. There is one option. And if it is not possible, it is in advanced stage of cancer and we are giving higher doses of bleomycin, that is the maximum tolerable dose, then we have no option but to monitor CT finding and clinical symptoms. The role of therapeutic drug monitoring is, you can say, I will say, has no role in fact. All of the drugs, as Abhishek sir has discussed, they follow non-linear kinetics. You will not even can interpret their plasma level and their assault to lung. In low plasma level, it has been found bleomycin-induced lung injuries are there. And even in higher levels, there are no injury because tissue sensitivity differs from person to person.
Yes. Thank you, sir. Thank you. So you mean to say it is dose-independent toxicity which has caused by the lot of group of drugs towards our lung.
Yeah.
Thank you, sir. Thank you. Thank you for your elaborative session on this answer on this question. So after this, we'll go to Dr. Abhijit Prajapati. I'm going to ask him, what are the groups of drugs those are going to cause ILDs most common? What are, just we have to elaborate those group of drugs, not to mention regarding treatment and all those things. Just please, Dr. Abhishek.
Yes, as I told in my presentation, the most common ILDs, the drugs we the groups of drugs which causes the ILD is the lung disease, and therapeutic agents and non-chemotherapeutic agents. Chemotherapeutic agents, the drugs like azathioprine, bleomycin, busulfan, chlorambucil, hydrocortisone, methotrexate, mitomycin C. These are the drugs which can cause this chronic pneumonitis or fibrosis or ILD. And in non-therapeutic agents, the drugs like amiodarone, NDTNF alpha, cocaine, gold, penicillamine, methotrexate, statins, etc. These are the drugs which can cause this chronic pneumonitis or fibrosis. And as I mentioned already in my PPT, the most common drugs which can cause this chronic pneumonitis or fibrosis are amiodarone, bleomycin, chlorambucil, this cyclophosphamide, and followed by methotrexate, nitrofurantoin, and statins.
Thank you, Dr. Abhishek. Most of the actually you can say this anti-cancer drugs, they are most commonly going to cause this our lung in the danger, or they are going to give our lung in the danger. So thanks for your elaborate response for this question. After this, I will come to our most important and most senior person of today's webinar, Dr. PC Kathuria, sir. Please. Uh, just brief on the pathophysiology of the drug-induced pulmonary edema. As we have seen, actually, first drug which was elaborated in the drug pulmonary edema and the drug-induced lung toxicity was the only one that was opiate and opioid. So, please, sir, what is your thought on this?
Thank you. My greetings to all again.
Thank you, sir. Welcome.
You see, once we discuss about the pulmonary edema, we should know that if there is a fluid in the interstitium, it's normally cleared by the lymphatic vessel. But if there is a fluid in the alveoli, then there is a transport mechanism due to the oncotic and the drug which causes the non-cardiogenic pulmonary edema, as you mentioned, the opiates, pain injections, the other, and Midorone also. Some other drugs, many drugs are there, like NFT can also be used. But in these cases, how the drug induces the reaction because of the leak in the kidney. So far, the books has mentioned the toxins they releases, but this is opposite to the ones we discussed of the high altitudes pulmonary edema. High altitudes, if you go, there is a oxygen level is low, so there is a vasoconstriction. So it is the extravasation of the fluid again. So both the way is there. Actually, the non-cardiogenic pulmonary edema is a big umbrella. It contains ARDS, it contains high altitude, pulmonary embolism, the other factors. This is the main pathology, is the pulmonary leak.
Thank you, sir. Thank you. So my next question goes to Dr. Abhishek Prajapati. Can you elaborate on the pathophysiology of drug-induced interstitial lung diseases? How it happens and what are the causes or what are the reasons to happen it? Please, Dr. Abhishek.
Yes, sir. So the most common pathophysiology which is being understood, the first one we need to understand is the genetic and host mechanism plays an important role in this pathophysiology or pathomechanism of the drug-induced lung injury. Means the drug response in one host will be the same as to the another host. So there may be different kind of mechanism, different kind of injuries with the same drug in different individuals. So this is the one basic principle of drug-induced lung injuries. Now, if we talk about the drug-induced lung injuries, in which ILD, in which mechanism plays a role, the important mechanism which plays a role is by cytotoxic damage to the lungs by the activated drugs. Here, the drug incorporated in the cytochrome P450 in endoplasmic reticulum, and which makes a very active drug, and which leads to the damage to the protein, lipids, and nucleic acid of the lungs. And another cytotoxic damage done by the different drugs in a different way, like bleomycin incorporated in the proteins of the lungs and damage, then it leads to the cytotoxic damage. If we talk about another drugs like nitrofurantoin, paraquat poisoning, or adriamycin, which do injury by redox recycling, means it causes the oxidative stress. And so another drugs like cyclophosphamide, it also causes some mechanism related to the oxygen metabolism. So these are the mechanism which can lead to the lung injury or in a form of interstitial lung disease. Another theory is heparin theory, and another theory is the immunologic mechanism, which different drugs. So at the end, if we conclude of the etiology causing ILD, it is by multiple ways drugs causing this drug-induced lung disease, and it is difficult to understand because it causing multiple injuries by each individual drug, like bleomycin and amidon causes 20 types of injury into lungs in a different way.
Thank you, Dr. Abhishek. Thank you. And I think one of the mechanism of injury by drug is free radical formation in our body, and which are toxic to our lung parenchyma, or you can say lung tissues, and that will giving rise to the development of the lung-induced drug toxicity. Thank you very much for your elaborative answer on this one. My next question goes to Dr. Pawan Gupta sir. Pawan Gupta sir, can you elaborate or can you give brief talk on the drug-induced bronchospasm?
Thank you for giving me this platform. Basically, drug-induced bronchospasm. This is caused by many drugs, and hardly any physicians, especially the chest physician, is uh, basically devoid of these kind of the side effects, because most of the drugs which we commonly use can cause the bronchospasm. So the one of the most common cause being the NSAIDs, and in the NSAIDs, aspirin, which contributes around more than 50% of the drug induced the bronchospasm. So the mechanism behind the NSAID causing the bronchospasm is the inhibition of the cyclooxygenase pathway, causing the decreased prostaglandins and increased leukotrienes. And it also alters the sensitivity of the leukotrienes. So basically, the NSAIDs induced bronchospasm, it occurs especially in the asthma, as Dr. Abhishek told that in the central trial, around 4 to 11% of the asthmatic patients, they are sensitive to the aspirin. So the symptoms, they appear within a minutes. So this is the most characteristic, that as soon as the drug is given, so symptoms, they appear within a minutes. Unlike in the some other drug induced fibrosis or the HSP, where the symptoms may take maybe days or months. The second thing is that it may be not only with the aspirin, but also with the cross reacting NSAIDs. So the treatment of, or the alternative therapy is giving the low dose of paracetamol or the salicylate or the chloroquines as a substitute for the NSAIDs. The second is the hypo or the desensitization of the aspirin. So that is required in that subset of the patients where there is the patients, they are refractory to the optimal medical therapy, and they require the unacceptably or the high dose of the corticosteroid to control their symptoms. And patients, they require the aspirin, especially the patients who are having the coronary artery disease. So the one is the withdrawal of the drug if it is possible, or the hyposensitization or the desensitization is the other thing which can be given for the NSAID induced bronchospasm. Now I comes to the ACE inhibitor, and there is a much hype about the ACE inhibitor causing the bronchospasm, but it is more associated with the dry cough. So the studies have clearly shown that ACE inhibitors, it can cause the dry cough, but the bronchospasm events are very rare. Now the beta adrenergic antagonist. So definitely the beta adrenergic antagonist, they have been shown to cause the wheezing or the bronchospasm even in the patients who are not having any obstructive airway disease in the past, like asthma or the COPD. We have seen one patient who was taking the eye drop beta adrenergic antagonist topically for the glaucoma, and over years he was having the wheezing or the dry cough. And when we evaluated, then we found out in the literature that even the topical eye drops of the beta adrenergic antagonist, they are systematically absorbed, and over the years may cause the bronchospasm. So the next is the like the radio contrast agents. So generally nowadays we are using the non-ionic low osmolality radio contrast agents, because it has been shown that the high osmolality iodinated radio contrast agents, they are associated with the bronchospasms. And similarly, the opioids like morphine, it is also well known cause for the bronchospasm. Now, there are medications which we think that this is for the asthma, like IV hydrocortisones, sodium chromoglycate, or the IV aminophyllines. But paradoxically, even these medications has also been shown to increase the bronchospasm in some subset of the patients. So, which patients may get these kind of the adverse or the paradoxical bronchospasm? It is unclear or unknown. So, we have to aware of these side effect of these medications, and we should have the bystanding the alternative medications and to control these kind of the side effects. So in conclusion, I will say that the drug induced bronchospasm, it can be caused by any drug routes, whether it is an inhalation route or the oral or the IV route,
Yes.
and the symptoms appear within a minutes. So one should aware which drugs, and we should have the alternative therapies available. Thank you.
Thank you, sir. Thank you for your elaborate. I don't need to say anything regarding this. You have explained each and everything in this answer. So my next question goes to Dr. Smitakshi Medhi. Just elaborate on this drug-induced lupus erythematosus. Just few words on the drug-induced lupus erythematosus you have to say to our audience.
Yes. Thank you, sir, for the opportunity. The thing is, like we have discussed in this webinar regarding the incidence and the prevalence of drug-induced lung disease, which is comparatively rare or less common in compared to other lung diseases. But if we see in case of drug-induced lupus, it comprises of about 6 to 12% of all lupus cases. So it is not that less a number if we see. And the most common drugs which cause drug-induced lupus is hydralazine, which is an antihypertensive that we use, and procainamide. Also, it is found in case of when we use isoniazid, rifampicin, and anti-TNF alpha blockers. And what happens is that the body's immune system reacts to this drug, to this pharmacological agent, and they start producing autoantibodies, which is the mechanism of lupus. So if we see hydralazine is one of the common agents which causes drug-induced lupus, and it has got a 5 to 10% increased risk. And in case of procainamide, the risk is even higher. And the symptoms of drug-induced lupus are comparatively less severe than we see in systemic lupus erythematosus. And the most common symptoms that we see are like maculopapular rash, or the patients may have arthralgia, fever, this kind of constitutional symptoms. And more commonly, we also see pleuritis and pleural effusion. And in long-term cases, suppose drugs have been used for a longer duration of time, then sometimes drug-induced lupus also has a hypersensitivity kind of reaction, and it may go into interstitial fibrosis. And the diagnostic criteria that we can see is that compared to other cases of systemic lupus erythematosus, drug-induced lupus, we all know antihistone antibodies is going to be positive in these cases. Yes. And the treatment is, as discussed in all other cases of drug-induced lung disease, we have to first try to withdraw the drug. We have to withdraw the drug and see the patient's response. And suppose the symptoms are quite severe, then we have to go for a short course of corticosteroids, depending upon the symptoms and the response of the patient over a period of months.
Yeah. Thanks, Dr. Smitakshi. Actually, main thing to diagnose this drug-induced lupus erythematosus is a demonstration of this antihistone antibodies in the blood of that patient. That is very, very important. And treatment, as you have mentioned, that is very clear. And at the end of this our today's webinar, we are going to come to that topic also. So thanks for your nice demonstration on this drug-induced lupus erythematosus. My next question again goes to Dr. Abhishek Prajapati. Can you elaborate or can you give brief on this drug-induced pleural disorders? What are the drugs which are going to cause this pleural disorders as far as our lung is concerned? Over to Dr. Abhishek.
If we talk about the pleural involvement by the drugs, the two main syndromes which are important, and one is pleural effusion and pneumothorax. So yes. Effusion, pleuritis followed by pleural effusion is the most common pleural manifestation of the drugs, and is mostly occurred because of these chemotherapeutic agents, and very rarely by some non-chemotherapeutic agents. The most common cause of a drug which causes pleural effusion in a very moderate to severe form is dasatinib, followed by imatinib. So dasatinib is a tyrosine kinase inhibitor which has been used for lymphoma treatment as well as some germ cell abdominal gastrointestinal stromal tumors. The incidence rate is mentioned around 28% at the end of the 1 year with dasatinib treatment. And we need to stop this the drug. We need to therapeutically tap the drugs, this effusion. And sometimes when it is reintroduced, it again causes the recurrent effusion. So the most common drug which causes symptomatic pleural effusion is dasatinib. The treatment is the same. We have to stop this drug and we have to observe. It followed by imatinib. Imatinib causes effusion in a very lesser form. Incidence rate is around only 0.8% to 1%. And up to around whenever patient is taken this drug for up to 5 years, then we can appreciate. So these are the two drugs. Another drugs are docetaxel, which also is a miscellaneous drug of molecular targeted therapy of these anti-cancer drugs. The mechanism here is the vascular leak, and it leads to fluid overload. And we have to add if we add diuretics along with these, then patients are settled. And in a very rare case, we have to stop this. And sometimes it has been mentioned. If we start dexamethasone along with this drug, then the chances of this fluid overload or fluid liquefaction are very less. So this is another way. Another drugs are pazopamib. Pazopamib is also a drug. It is a tyrosine kinase inhibitor, which is used in renal cell carcinoma or melanoma. And here also it causes the pleural effusion, and the incidence rate is around 3%. And here the mechanism is the same, vascular leak. Another drug which rarely causes the pleural effusions are amiodarone and methotrexate. Specifically, methotrexate most commonly causes pneumonitis followed by pulmonary fibrosis. In rare cases, causes acute chest pain syndrome because of it leads to pleuritis and pleural effusion. So whenever this methotrexate is going on, the patient is having typical symptomatic pleuritic chest pain, having a pain on deep inspiration, then we should screen for this pleuritis caused by methotrexate. And same way, amiodarone also causes in a very rare way, very rarely. Another drug is interleukin-2 here, which causes same the fluid overload by vascular leak. And if we stop this, if we add diuretics, the patients are settled. So mortality is very less for this injury. Now, if we talk about another group of drugs which causes pleural manifestation, these are the recreational drugs. So recreational drugs causes barotrauma, and it causes pneumothorax, pneumomediastinum, pneumoperitoneum, pneumomediastinum, and subacute emphysema in a larger extent. The cocaine, opioids, amphetamines, marijuana, all these can cause these pneumothoraxes and barotrauma. Cocaine can cause this cardiac this pericardial as well as pleural effusion. By the mechanism, it decreases sympathetic tone of the pulmonary vessel, and which leads to vascular leak. If we talk about the barotrauma pneumothorax, each and every these recreational drugs, they introduce, like in opiates, they introduce in via the supraclavicular injection, which may lead to this pulmonary injury and lead to pneumothorax. And in opioids, in another opioids, taking these individuals may be taking these opioid drugs for a longer duration. They may be suffering from septic puncture emboli because of the valvular involvement. And because of this septic puncture emboli, sometimes they may have a bilateral pneumothorax because of this rupture of this pulmonary emboli very rarely. If we talk about the opiates, another mention this pleural involvement is wooden chest syndrome, in which most common culprit is IV fentanyl. There are recent reports that so many individuals, so many youngsters have now this habit of IV fentanyl, which may lead to very restrictive type of chest wall abnormality because of the tightness of the respiratory muscles. And this fentanyl-induced tight chest wall syndrome also not reversible with the naloxone. So it happens very rarely, but when it happens, we have to intubate this patient and we have to relax, completely sedate and relax these patients. So these were another manifestation. Then another important mechanism which causes the pneumothorax or barotrauma in this recreational individual taking drugs is what they did when they inhale this drug. They try to use this mechanical. They try to take a very deep inspiration, then try to involve this Valsalva maneuver on deep inspiration, and try to exhale very deeply. So, if we talk about this marijuana, it has a potential to develop apical bleb because of this maneuver, and this may lead to the rupture of this bleb and spontaneous pneumothorax. So, another this mentioned the theory in the book if we talk about the cocaine users use this recreational drug, they inhale, and another person remains on the backside, and they give the pressure on the back. So they inhale deeply, they do Valsalva maneuver, and because of this back pressure by the other individual, this may lead to the positive intrathoracic pressure increase, and which may lead to the barotrauma. So these are the manifestations of these plural. These are the plural manifestations of the drugs. Very rarely, CAR-T therapy, this chimeric antigenic therapy. If we talk when we did refractory lymphoma, and here this agent it may lead to cytokine release syndrome. And the pleural effusion, symptomatic pleural effusion is one of the components of this CAR-T therapy. The cytokine release syndrome, we all these tocilizumab and steroids as in COVID. So these are the mentioned plural manifestation of the drugs which may cause to this lung injury.
Yeah. Thanks, Dr. Abhishek, for elaborative session on this drug-induced pleural disorders. Actually, vascular leak is one of the most common side effect of this, all of drugs, whatever he has mentioned, and which is going to cause this pleural complication as far as drug is concerned. Thanks, Dr. Abhishek, for this collaborative lecture on this drug-induced pleural disorders. So my next question is to Dr. Pawan Gupta, sir. Pawan Gupta, sir, your favorite question regarding this drug-induced hypersensitivity lung diseases. You have to speak on this one.
Basically, drug-induced hypersensitivity lung disease can be categorized as the hypersensitivity pneumonitis, or the second is the DRESS syndrome, which is very acute. And as Dr. Abhishek told about the Loeffler. So firstly, the hypersensitivity pneumonitis, the most common culprit drugs are the nitrofurantoin, methotrexate, and amiodarone. So in this, the picture or clinical picture, radiological and functional pulmonary function test, they all mimic the hypersensitivity pneumonitis. So clinical presentations, they may be an acute, subacute, or the chronic. So if it is an acute, then it may be within a days, or if it is in chronic, maybe years. So the symptoms of fever, chills, malaise, and dyspnea, they may be present. And the CT chest, basically, it in the acute form, it may shows the bilateral lower upper lobes ground glassing, centilobular nodularity, or the mosaic pattern. But in chronic form, it may behave as a fibrosis in the lower lobes. And pulmonary function test, it shows the decreased FVC, decreased diffusion capacity. So basically, the presentation is more like the hypersensitivity pneumonitis due to the other causes like the organic dust, the inorganic dust. So the treatment is the withdrawal of the culprit drugs. Now the second thing is the Loeffler syndromes because of the DRESS. DRESS is basically the drug rash with the eosinophilia and the systemic symptoms. And it can be caused by the chloramphenicol or the bleomycin also. And the symptoms are like the fever, cough, dyspnea, and the fleeting opacities on the chest X-ray. And that it occurs generally after 1 to 8 weeks of starting of the medications. And the bronchoscopy is the diagnostic clue in this because it shows the high CD4 count or the CD4 to CD8 ratios increased and eosinophilia. And the treatment is similar, that is the withdrawal of the culprit drugs. And in some severe cases, when the patients they land up in the respiratory failure, in that conditions, one can start with the glucocorticosteroids in a dose of 1 mg per kg per day.
Okay, sir. Thanks. Thanks for your development. Mentioning regarding all these drug-induced hypersensitivity lung diseases. No need to addition to this one. Next question I would like to ask Dr. Smitakshi Medhi regarding this. Can you brief on the drug-induced mediastinal disorders, Dr. Smitakshi, please? Over to you.
Yes. Drug-induced mediastinal disorders are comparatively rare compared to the drug-induced hypersensitivity reactions and drug-induced fibrosis that we encounter.
Yes.
But nevertheless, drug-induced mediastinal syndromes and mediastinal lymphadenopathy also occur in certain patients. So, if we take drug-induced mediastinal disorders, the most common drugs that are the culprit drugs are, one of the drugs is methotrexate. And methotrexate, it is one of the long-term effects of methotrexate. The short-term use of methotrexate won't cause mediastinal or hilar lymphadenopathy. But if we are using methotrexate for a longer duration, over months to years, in case of like in remission in maintenance treatment of leukemia or psoriasis, then the patients may have bilateral hilar and mediastinal lymphadenopathy, also cervical lymphadenopathy in certain cases. Another drug which is known to cause mediastinal lymphadenopathy is phenytoin. Phenytoin, which is an anti-seizure medication, and it has been shown that the use of phenytoin has a 4 to 10-fold risk of having lymphoproliferative disorders and mediastinal lymphadenopathies. And some of the lymphadenopathies that occur are usually self-resolution. They have self-resolution, spontaneous resolution, and some lymphadenopathy, they go on to progress and ultimately cause true lymphoma. So there are 4 categories of lymphadenopathy if we see in case of phenytoin. The first grade is actually hyperplasia, when we have hyperplasia of the lymph nodes. Second grade is pseudo lymphoma, which occurs like after a few months of therapy or with phenytoin. And if you stop or withdraw the drug, then lymphadenopathy gradually subsides and it regresses. Another is a pseudo lymphoma, which occurs after months of therapy with phenytoin, and then if you have withdrawn the drug, the lymph node regresses, but again it comes back, it recurs, and then it turns out to be a true lymphoma. And the fourth stage is a lymphoma, which occurs during on treatment with phenytoin. So these are the lymphadenopathy that we encounter with this hydantoin derivative. And another set of patients where we encounter mediastinal lymphadenopathy or hilar lymph nodes is the patient who are transplant recipients. And one of the most common immunosuppressants that we use during transplants is the cyclosporine. And it is known to cause lymphoproliferative disorder. There is also a term called post-transplant lymphoproliferative disorder, PTLD. And it is seen that if cyclosporine is used within months of therapy, patients may have increased mediastinal size of the mediastinal lymph nodes and hilar lymph nodes, and then they will go on to have dyspnea, persistent cough, refractory. So this one is encountered in case of cyclosporine. And if we see that if we decrease the dose of immunosuppression, then the lymph node spontaneously subsides on its own. And this is more commonly found in case of lung transplant or heart-lung transplant. It is seen that in these kind of organ recipients, PTLD is more common. Then another common drug that we use more frequently are the steroids, which also causes mediastinal syndrome, that is mediastinal lipomatosis. So with steroids, we all know that patients have Cushing syndrome, and along with Cushing syndrome, you can find that in some patients, they may also have enlarged lymph nodes. So that is another common side effect of steroids. So if we do an X-ray or a CT scan, we will see that there are enlarged mediastinal lymph nodes, even cervical lymph nodes are enlarged, and the nodes are distributed in the centripetal manner. So this is one of the thing. And the treatment is usually withdrawal of the drug. So in case of steroid also, if we withdraw the steroid and if we give it in gradually tapering doses, the lymph node subsides on its own.
Yeah, thanks, Dr. Smitakshi. Actually, most of the immunosuppressive drugs or chemotherapeutic drugs, they are going to cause harm to our lung, which is our important organ. And as far as pulmonologist is concerned, it's very, very important to look after this organ. So when any patient is on chemotherapeutic agent or any immunosuppressive drug, we have to keep very, very close watch on these side effects, whatever we are discussing. So thanks, Dr. Smitakshi, for your elaborate session on this drug-induced mediastinal disorder. After this, I would like to ask one question to Dr. Pawan Gupta sir regarding this methotrexate, actually, which is very much common culprit for the development of lot of lung disorders or lung toxicity, that is methotrexate. Sir, can you elaborate on the drug induced means methotrexate induced toxicity as far as our colleague is concerned or our important organ is concerned, that is lung. Over to Dr. Abhishek. Sorry, Pawan Gupta, sir.
Yeah, basically there is a lot of times the confusions arise between the rheumatologist and pulmonologist, because the patients of the rheumatoid arthritis, they ask us for whether to start the methotrexate or no for the consideration of the ILD. So for it has been seen that the lung toxicity for with the methotrexate, it can arise within a few days even after giving the IV methotrexate, or it may takes time up to a months or years after giving a low dose of oral methotrexate, which we generally give for rheumatoid arthritis patients. So, but the frequency with which the methotrexate causes the lung injury, it is still very difficult to assess. And the most common, the pathogenesis or the pathology is the causing the hypersensitivity pneumonitis. Then it may also cause the organizing pneumonitis or AIP kind of picture, that is acute interstitial pneumonia. And pleural effusion is very rare. So this is very important that it is pleural effusion occurs in infrequently. And basically, the second thing is that other than the methotrexate pneumonitis, it also can increase the chances of opportunistic infections like the PCP. Methotrexate can, as it has also been seen to increase the chances of lymphoproliferative disorders. So there are certain the risk factors which has been studied which can increase the chance of methotrexate pneumonitis. These are like the age more than 60 years, if there is a previous underlying lung disease, or patient is having hypoalbuminemia or diabetes mellitus. Dose. So if there is a higher dose of methotrexate as compared to the lower dose, the higher dose are associated with increased risk of methotrexate induced lung injury. Similarly, the daily dose as compared to the weekly dose, they are associated with more chances of toxicity. The clinical manifestation, it depends on whether it is being given in a low dose or the high dose. If it is given in the low dose, then it may takes a long time to for the symptoms to occur. But the subacute presentation is the most common one, where the progression of the symptoms, it occurs within a month. So the same symptoms like dry cough or dyspnea or the tachypnea, so all these kind of the symptoms which progress over the months. Now the diagnostic approach. So how to approach the patients who is having who is receiving the methotrexate. So basically, first thing is the detailed medicational history present and the past dose of the methotrexate and duration of the methotrexate which is receiving. Other than, there is certain radiological criteria on the CT scan, because most common presentation on the CT scan is the hypersensitivity pneumonitis. So that's why the central nodularity, ground glassing, it may be seen. So they, up till now we had some kind of intuition in our mind that it generally caused the ILD, but it is not like this. ILD is very infrequent, so it may be seen when it is exposed for a longer duration of the time. So that's why the chronic picture is very rare, or fibrosis is rare. Most of the time it is the ground glassing or the central lobular nodularity. So pulmonary function test also shows the decreased diffusion capacity or the total lung capacity. Uh, so now the role of bronchoscopy and the biopsy, it is not to diagnose the methotrexate induced lung injury, but to rule out the other causes. So there are certain criteria which has been set up, major or minor criteria. Major criteria are the hypersensitivity pneumonitis type picture on the histopathology, characteristic radiological findings, and negative, and to rule out the other etiologies. So these three major criteria are there. And there are five criteria: unexplained dyspnea, unexplained dry cough, then DLCO is less than 70%, saturation is less than 90% at room air, right? So these, there are five criteria which are the minor. So if there are two major or three of the five minor criteria are present, then this may be labeled as methotrexate pneumonitis or methotrexate induced lung injury. So methotrexate induced lung injury, we as I said, that there is always some controversy whether we should start the whether we should do the PFT or not prior to starting the methotrexate. So I personally do the PFT in every patient who is having some sort of exertional dyspnea, or there is some abnormality on the chest X-ray. Pre-treatment chest X-ray we do, and if there is some abnormalities there, then we definitely do the PFT. But there is no role of any surveillance spirometry or the lung volumes or the diffusion capacity to detect the early diagnosis of methotrexate induced lung injury. So if patient is on methotrexate, and if we say that we can detect it early by doing the surveillance PFT, that is not there in the studies. So treatment, definitely it is a withdrawal of the drug and glucocorticosteroid if there is a acute or progressive or the severe presentation is there.
Yes, thanks. Thanks for this is actually long question on methotrexate induced drug induced drug toxicity. Thank you, sir. Thank you. Each and everything you have mentioned over here. So we go to our next question, and next question is how do we detect any reversible lung damage? We have discussed a lot of regarding this drug induced manifestations like muscular or lupus or this pleural or pulmonary, whatever it is we have discussed till now. So we'll come to the prevention with our esteemed panelist, Dr. Mohammed Hussain. I would like to ask him, how do we detect any reversible lung damage in the initial stage? Please, over to you, sir. Dr. Hussain, sir.
Yeah. National Cancer Institute common adverse event terminology criteria for drug-induced ILD. Radiologically, they have defined grade 1 is mild, which is asymptomatic, only detected radiologically. Grade 2 is moderate, which is symptomatic but no limitation of activity. Grade 3 is severe with symptomatic with limitation of activity, and these patients require oxygen. Grade 4 is life-threatening, they require ventilator support, and grade 5 is fatal. So in this, grade 1, 2 is reversible, and grade 3 is to some extent is reversible. So based on this criteria, and also radiologically, if ground glassing is there or nodules are there, then it is reversible. But if it is going into traction bronchiectasis and all those things, then it will not be reversible. So you have to suspect, and it is a diagnosis of exclusion. So you have to reduce the dosage of the drug often.
Thanks. Actually, each and every means whatever literature will go regarding this drug-induced lung diseases, everybody says that it is a diagnosis of exclusion, and each and after excluding all the causes of whatever causing lung injury, then finally we have to come to the drug-induced lung diseases. So thanks for your this feedback regarding this early demonstration of lung injury. Thank you, sir. Next, I will come to Dr. Kathuria, sir. General approach to the management of drug-induced ILDs. So, how we should go, how we should proceed regarding this drug-induced lung diseases, whatever it is ILD or some other disease which is caused by the drug which are giving to our patients. So please,
Friends,
what do you say? Thank you.
Friends, most of us has given a very clarification regarding the treatment also, but in clinical practice, sometimes it's very difficult. So what we go for the classifications. Once you know the classification, which specific drug induces the immunological reaction, then it is easy for us to treat. Holistic point of view, we differentiate into the two types of the drug reactions, type A and type B. Type A is it is a predictable and dose dependent. Like if you increase the warfarin, you may increase the bleeding. So we know the dose, so dose is very important with type. But the type B is unpredictable. So type B has been Jelen-Kum, if you remember, 1960 classification was done, type 1, 2, and 3. And in 1990, again it was extended to type 4 into type 1, A, B, C, and D. But in 2023, now most of the drugs we classify under 5 categories. Number one is the antibody dependent, means the IgE, which induces the anaphylactic reactions, and also we differentiate the cytokine release storm. Now, with the advent of the antibodies, is also produce the fever, arthalgia, back pain. So also this also monoclonal antibodies comes into the domain of the anaphylaxis. So these are serum tryptase we do in case of the Ig mediated, but in case of the cytokine release syndrome, we do in case of the IL-6 as we have seen in during the COVID-19 IL. And then comes the IgG dependent. IgG as well as which is a cytotoxic, is the drug induces by the ADCC, antigen dependent cell cytotoxicity. And then comes the immune complex reactions. Most of the hypersensitive pneumonitis, as we discussed, they comes under this pneumonia like lupus or anti-histamine antibodies or this drug. All these treatment we know depend on the avoidance as well the dose of the steroid. Then there is another which Dr. Pawan Gupta mentioned. They are receptor dependent. Receptor dependent means that the COX-1 inhibitor activate leukotrienes and the suppression of the BGE2. And secondly, there is a MRGPRX2 receptor, where the RCMX, the radio contrast media acts, and these patients, they need the pre-medication before we use for the RCM. And third group is the bradykinin overproduction dependent, as Dr. Gupta mentioned, the is. So these drugs, they need the avoidance only. The most important, the drug-induced lung disease comes in the domain of the epithelial damage.
Yes.
Epithelial damage comes, whatever we discussed as today, hypersensitive pneumonitis, organizing pneumonitis, eosinophilic pneumonia, NSIP, even DAD also, they comes under this domain. So the treatment is avoidance plus steroid. But steroid, like in boob, steroid may act poorly, but in some other case, it may not act. So we should know the dose as well as the avoidance. And the third most important, again, come the drugs which includes the pulmonary vascular diseases. That comes under the domain of the metabolic disorders, because now for the last 10 years, the main focus of the research on the microbiome and the bacterial metabolites, as well as the other diabetes, obesity, they also dysregulate our immune system. And the most of the drugs, which are like, especially the drugs is a fenfluramine and appetite suppressant or OCS, the oral corticosteroids, are the estrogens or oral contraceptives. They produces the peripheral. So all these drugs has been differentiated under this domain, and most of the drugs, they need avoidance. And most important, in an Ig mediated, they need the desensitization, and desensitization the only in the IgE as well as in the monoclonal antibodies. So that is the special protocol.
Yes. Thank you for your very nice words regarding this, whatever we have to do regarding this drug-induced lung diseases. Thank you, sir. My next question is to Dr. Hussain, sir.
Yes.
Hussain, sir, treatment of drug-induced lung diseases. We have discussed each and everything. Pathophysiology, we have discussed. We have discussed management part, as Kathuria sir has mentioned. So coming towards the end of our this thing, whatever disease has caused, each and every disease, we have to go for the treatment. So what is treatment for the drug-induced lung diseases?
Yes.
We have to
First of all, we have to reduce the dosage or stop if needed offending drug. Give symptomatic treatment. If the symptoms are depending on mild, moderate, or severe, moderate to severe, we may have to give steroids, prednisolone 1 mg per kg, and oxygen inhalation if it is at the
duration of steroids. Can you elaborate?
Depends on amiodarone. You have to give for 1 to 2 months or longer periods also, depending on which drug. For if it is drug-induced bronchospasm, it does not require only 1 day treatment or 2 days treatment will be sufficient.
Thank you, sir. Thank you. So, most common treatment or majority of what pulmonologists will do, they will stop the drugs and whatever is going on for that patient, and they will wait and watch. And followed by they will add the steroids, which is everybody says it is magical drug or magic drug for each and every condition of our disease. So Thanks, sir. Next question goes to Sudhakar Choudhury, sir. Role of pharmacovigilance in the prevention of drug use. So, from treatment we are coming to the prevention of the disease. How to prevent such kind of hazards or such kind of diseases in our patients? That we have to make. Over to you,
As
sir.
as my seniors and colleagues all have pranam to Dr. Kathuria sir, and everything has been already discussed. But now, actually, I can want to go through pharmacovigilance by type A and type B reactions. Actually, type A reaction is related to the pharmacological mechanism of the drug. So that is augmented reaction, A for augmented. So that is fully, not fully, but partially in our control that we can avoid such type of reactions. As Pawan sir has already told about topical beta blockers, I have few instances, and remember the beta blocker is non-selective beta blocker. Some cardiac patient taking selective beta blockers, so these type of interactions will not see in these situations. But whenever the non-cardio selective beta blocker, that is beta 1 and beta 2 combined blocker, propranolol, when used in the treatment of migraine, essential tremor, or anxiety neurosis prophylaxis, then something special happens, as I have seen. One important case is a 23-year-old girl, lady, you can say, was suffering from chronic migraine and was on propranolol prophylaxis. The physician was unaware of her history of atopic asthma. He prescribed it, and after 7 to 8 days, she suddenly rushed to emergency after having some exposure to dust and pollen. I think there was severe bronchospasm, and when salbutamol nebulization was there, as the beta 2 receptors were blocked, I can presume that the longer duration of salbutamol treatment to surmount that beta blockade by propranolol had the overcome was that the hypokalemia, what we transiently get during salbutamol treatment, which is around 3 to 3.5 millimole hypokalemia. In this situation, the overdose of salbutamol to surmount the beta 2 blocker, propranolol, the potassium level was around 2.5 and cardiac symptoms start developing. So such type of thing we can avoid just a simple history. Whenever we are giving beta 1, beta 2 blocker propranolol to any patients like migraine, tremor, anxiety neurosis, we can avoid bronchospasm if we can take the history of asthma in the patient. I think so. Second thing, that is type A adverse drug reaction, what we can, that is in our hand, we can prevent. Then aspirin sensitive asthma, as sir told. In MI, myocardial infarction management or chronic angina management, the dose is around 300. In inflammatory bowel disease, the same salicylates are given around in 1 gram dosage. In rheumatic fever, the same as 1 gram. What is happening? Aspirin sensitive asthma also depends on the dose of aspirin. In MI management, the incidence of aspirin sensitive asthma is very low, as the dose is low. To promote lipoxygenase pathway in eosinophil, mast cell, and neutrophil, this dose gets quite insufficient to produce such type of effect. But mesalazine and other anti-inflammatory drugs, when we are giving in higher doses salicylates in IBD, inflammatory bowel disease, or in a child having acute rheumatic fever and having carditis and all this, the chances of aspirin sensitive asthma is quite higher. So as soon as symptoms starts in these type of patients, we have to decrease the dose, as these are prime part of management in IBD as well as in you can say rheumatic fever. And this AC inhibitor induced cough, I just want to say the increased level of bradykinin. It will only AC inhibitor induce bronchospasm If there is coexisting COPD, then only bronchospasm will be evident. Otherwise, simple AC inhibitor will not lead to any type of serious consequences in non-asthmatic patients. And if we need the cardiac protectivity, which is also due to bradykinin, and its AC inhibitors, it is already due to bradykinin, and we need this cardiac protectivity, then people having mild COPD, then we can give the AC inhibitors in lower doses to get the therapeutic benefit. That 81 antagonist will not provide cardiac benefit as AC inhibitors. After these type A reactions, last is just 1 minute, sir. Type B reactions. Type B reactions.
Please.
It is beyond our control, sir. It is beyond our control because maximum cases, the cytotoxicity that is happening, the drug forms insoluble complexes with tissue proteins and producing such type of consequences. Immune reactions are there, but direct cytotoxicity is the most important pathology. The only preventive aspect we can say that the D challenge, that is, as soon as we have discovered the assault, we must stop the molecule. Number one. This is the biggest and the first line management. Because assault, whenever there will be no assault, the injury that has been already produced, it will get recovered in 60 to 70% cases, even in cases of bleomycin also. But if we continuing this medication without, there are some issues like risk benefit. We used to give the drug, but if bleomycin is given for a longer duration or amiodarone 400 milligram BD for more than 6 months, then the lung injury, which was reversible in initial period, will be definitely reversible, and the assault we can't reverse, and patient will have lifetime consequences regarding dyspnea and all this. So for type B reactions, I can only say one is to stop the drug immediately. Alternatively, steroids and all this my respected seniors have told. In pharmacovigilance, I can only say two scales are there. What is WHO Uppsala monitoring scale, and second one is Naranjo's algorithm for early diagnosis of these drug-induced lung disease, so that at least de-challenge can be possible. And remember, the toughest thing is that in an already assaulted lung, having primary lung disease, to make a diagnosis of superimposed drug-induced lung disease is very difficult. And here, we need to follow the two scales. One is Naranjo scales and WHO Uppsala monitoring scale. Temporal association, that is the period of latency. D-challenge, you stop the drug. Agar mechanism of action, mechanism of assault is slow, slowly the improvement will also be there. But you have to stop the drug. Don't need for re-challenge. And lastly, we must, as the sir is there, I just want to request that there should be some formulary in hospitals regarding such type of toxicity, so that these might not be overlooked. And lastly, before I conclude, one last thing. A term is known as SUSAR, SUSAR, which is emerging nowadays, suspected, unexpected, serious adverse reaction. And among these category, drug-induced lung toxicities are coming also. We are reporting IPC2, IPC Ghaziabad. There are suspected drugs. What we have discussed, 600 and more drugs. Beyond that, there are some drugs which are probably producing lung assaults. So I think this much I can tell, that many more to develop. And thanks a lot for patiently listening.
Thanks, thanks, and thanks to NH Krishna sir for formulating all those things. So he has messaged in between to all of us that there are around 1222 logins as of this webinar is concerned. So I would like to announce this one. So that is great, and thanks to CCI and long live CCI, I would say. And sir, Choudhury sir, as you mentioned regarding this Pharmacovigilance. That is very, very nice. And I can't say any word beyond you, as you have already mentioned each and every.
You can say, definitely,
Yeah,
sir.
yeah. But whatever is the drug side effects, main thing is we have to desensitize. That is what you have also explained. We have to stop whatever is
TCNS.
yeah. We have to keep the strict vigilance, or you have to keep good watch on all those things whenever you are starting any new drugs to any patients, and you have to watch for the adverse drug events also. So whenever you are suspecting any adverse drug reaction, first and foremost thing is you have to desensitize that patient. We have to stop that drug, whatever period is required. Don't know whatever period is required, but we have to stop that initially. That is very, very important step and very, very important treatment as far as drug induced lung disease is concerned. Thank you, sir.
Thanks, sir.
With this your great elaboration on this pharmacovigilance, I would come to PC Kathuria, sir. He's senior most in our today's panel. Sir, I would like to ask one question regarding medical legal aspect of the drug-induced lung diseases. Is you have, if any patient has developed some drug-induced lung disease, and it is can he sue us, because each and everybody in this country today is against the doctor. I don't think you are agree or disagree with me. I don't know, but
Yeah,
each and every law and everything is going against doctor. What we have done as a cream of society to them, I don't know, but this is fact and this is what is happening as far as India is concerned. So, sir, anybody is coming to us with the drug-induced side effects, and he say, I am going to sue you because this drug you have given, and it has caused this kind of side effect to me, and such kind of things. How to deal with it? Please, sir, your opinion is.
my submissions to all of you, because I faced myself the 3 cases of the at my center, the hypersensitivity reaction. They try to sue me, but under table we table. The reason was there at that time in 1992, we were not knowing what is the emergency action plan at that time. It was not categorized as it was the crude extracts which we gave, and the patients within 15-20 minutes he got it. So from that onward, we have consulted our legal, and he advised few little things which is most important. That is the TC. You must have a competence. Well, number 1C is the competence. That it is the, you must know the update what is happening in the rest part of the world. And second is the consent. And once you take the consent, then you must ask the patients to write the case sheet with his own hand, not by yourself. Because you can manipulate, but the patient cannot manipulate. That is the most legal part. And second, consent at the last page of the case sheet must be taken with the witness also. You see, second, after the consent, care is also most important. We should have to explain to the patients everything, what we are doing. So I always give, whenever I give the shots of the allergy shots, adrenaline must be standby. Emergency kit must be with us. We don't know. Patients took any of the drugs, some of the drugs like the induced anaphylaxis, and some of the drugs like the other like RCM, if you are giving radio contrast media, they can produce reactions, nothing can be done. So pre-medication, the second point, now the guidelines is there that the pre-medication, those suspected anaphylaxis must be given, and serum tryptase is the take-home message. And most of the recently we have got a case in a nearby nursing home that she was aborted due to some reason, but the anesthetist they give the overdose. We don't know, but the patient died. Q is going on. So what we should do, the pre-anesthetic checkup, the serum tryptase, if there is a history of the anaphylaxis. We don't know the patient may have got mast cell activation syndrome. We don't know the patient has a history of the idiopathic anaphylaxis in the past. When the NSAID induced, first stop is the monoclonal antibodies. Chemotherapy we do rarely we use. It is the job of the oncologist. But we face antibiotics, NSAID, and peri-anesthetic agents, which I must tell the 4 agents which will Fenta, Meta, Propofol, and the atropine. That should be skin test. If you want to any surgical intervention, because there the specificity and the sensitivity of the skin test is more than 95%. And this we have touched. We have a patient. Everybody denied to do surgical intervention, and we admit in ICU, and then we plan desensitization accordingly, and the patient was fit. So take-home message is only that in perioperative emergency action plan and 3C is the submission that we have. Whatever we write, it should be asked by the patient and in his own hand, and that is the best. Thank you.
Thank you, sir. Thank you. Thank you. No words beyond you. Thank you. So we are coming to just end up this seminar or webinar, which has been designed by our beloved Dr. H. Putna sir. So at last, we are going to see few audience questions. There are few audience questions. We have to attend those questions. I'll be asking this question regarding this methotrexate induced. Can methotrexate can cause interstitial lung disease? Gupta sir. Gupta
Yeah,
sir.
methotrexate pneumonitis is very common, but regarding the methotrexate induced interstitial lung disease, I will say it is very infrequent, because for that patients require to have a prolonged exposure of low dose of methotrexate for years, and by that time within a month the patient is having the increased symptomatology, radiological changes. Then when we assess the patients, then we come to know that this may be because of the methotrexate, and so we intervene in between. So that's why still now the methotrexate pneumonitis or the acute or the subacute kind of the presentations are more common as compared to the chronic presentations. So ILD is still infrequent as compared to the acute or the subacute presentation.
Okay. Thanks. This question was asked by Dr. Harendra Thakkar, who is from Gujarat, Ahmedabad. So thank you, sir, for your answer for this question from our audience, beloved audience, you can say. Second question is from Dr. Tridip Chatterjee, who is actually very much active at his, you can say, geriatric age. What he has asked is from Mumbai, Maharashtra. What he has asked that among beta blockers, best is bisoprolol. But what is the data about less expensive atenolol and metoprolol? Anybody can take this question regarding this. We'll say cardioselective beta blockers and all those things. That is bisoprolol. But what we can do with this less expensive atenolol and metoprolol? Patient is from poor background or poor background.
Atenolol and bisoprolol are equally safe in case of patients who have bronchial asthma or COPD, because they are cardioselective beta blockers and they mainly act on the beta 1 receptor which is present in the heart. But the non-selective beta blockers like propranolol and carvedilol, levetolol, these are the beta blockers which act both on the B1 plus B2 receptors. And as we all know, B2 receptors are also present in the bronchial musculature. So that is going to cause a inhibitory action on the beta 2 agonist. So these are the beta blockers which I think are not cardioselective, and they are the ones which will cause bronchospasm or, like sir has mentioned that patient was using propranolol, but they had to use a higher dose of salbutamol to overcome those cardiac side effects, or the bronchospasm was not reducing in the usual dose. So these are the beta blockers which we should be careful in using in patients of bronchial asthma or COPD or any other condition causing bronchospasm. These are propranolol, carvedilol, and labetalol. Atenolol and bisoprolol, I think, are safe.
Okay. Thanks. Again, he is asking one more question. How common is NSAIDs causing bronchospasm, and which molecule is the most commonest?
NSAID,
Yeah,
so
please.
out of all the, as I mentioned, that out of all the drug-induced bronchospasm, so NSAID they contribute around 2/3 of part, and out of these, even the aspirin it contributes around more than 50%.
Okay.
So that's why the aspirin is the most common NSAID to cause the bronchospasm. And out of all, because we most commonly use the NSAID, so that's why the proportion of the NSAID causing the bronchospasm is more. So the answer to this question is definitely aspirin is still the most common cause for the bronchospasm.
Thank you, sir. Thank you. Again, we have got. Hello.
Just I want to say one thing.
Please go on.
It was between atenolol and metoprolol. Which one is better? Just a few moments back, as Madam has answered.
You can go ahead.
Which I just want to add one thing.
Yeah, please.
If long-term safety profile is concerned, I will put always metoprolol above, as atenolol-induced toxicity is very common after using at least 12 to 18 months. Like in young generation, loss of libido is one of the dangerous outcome, I can say. So if I have to choose between, if anyone has to choose between two molecules, metoprolol will be far better than atenolol.
Okay. Thanks, sir. Thanks for your.
Here, I can have one point which is most important as per the literature. In asthma, none of the beta blockers should be advised.
Yes, sir.
In asthma.
Yes.
In COPD, because there is no change in the FEV. That should be given. COPD study says can be given, but in asthma, if patients belongs to atopic constitution, none of it.
Because COPD is a multisystemic disorder, or there are so many extra pulmonary manifestations of the COPD, so we have to tackle with other comorbid results. Thank you, sir. Thank you for your.
The term we use cardioselective beta blocker, but actually it is cardioselective. A minute portion, it can have selectivity for beta 2 receptor also.
Yes, sir.
So that's why sir is saying that no beta blockers should not be used in cases of
Again, one question from our Tibib Chachadi sir from Mumbai. What he says, for respiratory muscle weakness, especially in the critical patients on ventilator, use of aminoglycoside plus neuroparalytic agents, drugs, when used for longer period may cause a, what he has said, I don't know, but may cause a muscle weakness, he might be saying that one. But does aminoglycoside alone use can cause respiratory muscle weakness? Anyone can take this. This is what he is saying. Combined aminoglycoside plus neuroparalytic agents, they are going to cause a muscle weakness, or you can say critical illness, myopathy. And does aminoglycoside alone use can cause this muscle weakness or critical illness, myopathy? Anyone can take this question.
Yeah. Please. Actually, these drugs stops neuromuscular transmission. All the mycins, they used to block acetylcholine release in neuromuscular ending, and as well as they also occupy the nicotinic receptors. That is I'm telling the actually basic thing actually, but it can solitarily lead to neuromuscular weakness if it is used for a particular period.
Thanks. Thank you, sir. Again, our young pulmonologist, Dr. Tibib Chachadi, again he is asking one more question. Lipoid pneumonia due to certain old laxatives. Kindly elaborate on this one. Lipoid pneumonia due to the certain old laxatives. Anybody can?
This is lipoid pneumonia is a inhalation lung injury, and old laxative, I think, sir is asking that Mindal as a laxative were used, and sometimes because of the inappropriate inhalation of these mineral oils as of these laxatives, if one can have a inhalation lung injury or lifeboat pneumonia. As we understood the pathophysiology of this drug-induced lung injury, its trace or rule is a it is an interaction of the drug and genetic host factors. So anyone can have any type of lung injury of the any drug. So it inhalation injury because of these bundle oil or laxatives. Already it has been mentioned in the literature quite well. It can cause lipopneumonia. We can have a diagnosis by temporal relation. It is an presentation and typical patient in a if patient having a very severe disease, he may have a crazy paying pattern, or one can have a that kind of pattern for which we can have a treatment like whole lung lavage may be required. So very rare, but it may occur. So for lipopneumonia, we have to give supportive treatment, steroids, oxygen, supportive respiratory therapy. If it is a very severe, it is in severe form, and having a very crazy pairing pattern, and then the treatment we may use whole lung lavage for that severe lipopneumonia.
Yeah, yeah. I think mainstay of treatment is the whole lung lavage for this such kind of pneumonias. Thank you, sir. Thank you, thank you. And one last question, and we are going to close our session after this question. That is from Dr. Madhav Kulkarni from Karnataka, Bangalore. What he says that benzyl inhalation and toxicity may cause lung diseases. So I don't know what he is going to ask or what.
Tincture benzoin?
He has mentioned only benzoin inhalation toxicity may cause maybe lung diseases like that. He has written. I don't know what is.
Even tincture benzoin. Then tincture benzoin
might be that way. You can go ahead, please.
Benzoin inhalation is very soothing congestion therapy in common cold. So it is we have to check the literature. At present, up till now, don't know about this. Benzoin in lung injury, don't know.
Right. So thank you all of you, and thank you CCI. Long live CCI. Thank you NH Krishna sir. And I would come to the end of this session with two-liners from each of our panelists. First and foremost, Dr. PC Kathuria sir, what you would like to say in two-liners regarding this our today's webinar, that is drug-induced lung diseases. Please, sir.
Yesterday was the great day we celebrate. Again, today is the great day we celebrate. For drug-induced lung disease.
Okay, sir. Thank you, sir.
Now we are on the moon.
Yeah. We have to go on moon after this one. Dr. Hussain, sir, please.
Yeah, excellent presentations and excellent moderation. Yes, first we should have high index of suspicion and we should stop the offending agent whenever we feel like, because it is a diagnosis of exclusion.
Yes. Thank you, sir. Thank you. Pawan Gupta, sir, please. You are two
we should always make the patient and the attendant in confidence whenever we have to stop the culprit drugs, and well counseling, as Dr. Kathuria sir has said, and because nowadays the medical legal problems are more, so
everybody is behind us.
Important. So well consent and well counseling is the important.
Yes. Thank you, sir. Dr. Choudhury, sir.
Just I would like to say I would just like to focus before ending that we must keep an eye on SUSAR, that is suspected unexpected serious adverse reaction, in which pulmonary toxicity also lies. New molecules, immunomodulators, immune suppressants, they are vigorously introduced in market, and lung toxicity is very evident in these molecules. So for SUSAR, I would like to request that everyone must be aware with Naranjo scale and WHO MMC scale, so that we can make an early diagnosis to prevent the newer drug-induced lung toxicities. Thank you.
Thanks, sir. Thanks. Great. Dr. Abhishek.
Drug-induced lung injury, we have to establish a temporal relation to diagnose it. there must be some duration after which lung injury should be established. And if any confusion about this drug injury, then we can check pneumotox.com, www.pneumotox.com. It is an excellent website. Any confusion, we can clear on that.
Yes, thank you. Thank you. Dr. Smitakshi, please, your 2 lines on this today's our webinar.
Yes, drug-induced lung injury is a diagnosis of exclusion, like we have elaborately discussed. So we should try to exclude all other probable diagnoses, like any sort of infection, atypical infection, any other causes of lung injury or interstitial lung disease. And when everything is ruled out, then we should go for drug-induced lung injury, and we should be prompt in withdrawing the drug, which is the suspected to be the culprit agent. And like sir has told, regarding the medical legal aspects, I think we should nowadays take a proper consent from the patient, or explain to him before starting any new drug that this is the drug and these are the probable side effects that may occur. So before starting the drug, I think we should have a good counseling and talk with the patient party and then start the drug. No matter, even after that, some drug-induced lung injury may occur, but I think a proper counseling will go a long way ahead.
Before starting the any drug, most of this immunosuppressive or chemotherapy drugs, I think we should have very good counseling session with the patient as well as with the relatives. That will save us from the medical legal aspect of such kind of things, which may happen in the future. Till now, I mean, as far as my experience concerned, I don't have come across such kind of any medical legal aspect, but it can happen. So we should take in the patient as well as his family into the confidence, and we should tell before starting that drug, and that will prevent us from the lot of complications which are going to happen in the future. So with these remarks, I would like to conclude this today's our webinar. And again, I would like to thank to our CCI President or Founder President Dr. N.H. Krishna sir, Dr. Atri Gangopadhyay sir, and Dr. Ashish Dubey, who is current National President of our CCI, and Dr. Anil Maske, who is National General Secretary of our CCI, which body, as far as current scenario is concerned, keeping us together, that is CCI, I would say. And I will again thank you for this CCI main founder, and we conclude this our today's session, that is drug-induced lung diseases. Thanks for our thanks to our all.
Thanks to our moderator also for a wonderful presentation.
Yeah, thank you, sir. Thank you, sir. Thank you.
Thank you.